I'm just going to say maybe one-liner on molecular profiling. You've heard about precision medicine or tailoring the treatment to individual patient for different cancers. You might have seen advertisements regarding that. What does that mean? We have moved from an era where we would have a treatment based on the diagnosis of breast cancer, this is the treatment. Colon cancer, this is the treatment. We have really moved from that era to individualized treatment based on individual cancer genetics. So we do a biopsy, take the tissue out, send it for genetic testing. It gets sent to some fancy lab outside. They run a lot of genetics tests on the DNA of the tumor, and they tell us if there are any particular mutations unique to that particular patient. Okay? And sometimes we get lucky and we have a mutation for which there is a drug design. And those mutations can carry across these. For example, let's take a mutation called BRAF, B-R-A-F. This mutation is seen very commonly in melanoma or skin cancer. But infrequently we can see it in colon cancer, in sometimes high-grade neuroendocrine cancer. So if there is a drug, which there is, if it works for one cancer, it can work for other cancers as well. So that's the advantage of testing for mutations, because we can have and use those drugs from one cancer to other cancer as long as those are targetable mutations. Many times mutations are not targetable, okay? In low-grade NETs, the chance of us finding a good mutation to target is very less, although these things are evolving. In high-grade neuroendocrine cancers, the chance of us finding a targetable mutation is almost 1 to 2 in 10 people. So we are routinely doing genetic testing in high-grade neuroendocrine cancer for sure. But this is an area to keep a very close eye on, and things are evolving towards betterment. We have better, faster genetic tests, cheaper genetic tests. 10 years back, it was probably a Herculean task. Now it's easy. We quick blood test and we get the results in 2 weeks. And if there's a mutation, we might have added treatment options. So that's basically the role of molecular profiling in neuroendocrine cancer. It's a science in evolution right now. Okay, great. So we are in the very last Q&A session. If you have questions, please feel free to write them and give it to Bob, or at the end, if you can maybe even raise a hand and ask. So we'll start off, or we have a microphone, so feel free to kind of ask your question. All right, so interesting question, and I've been getting a lot of this similar questions from my patients as well. Thoughts on neuroendocrine tumor patients taking Ozempic? So Sasha, this is a great question for you. What is Ozempic? And then there is a very peculiar side effect of Ozempic, which I think Dr. Del Rivero can throw some light on, related to thyroid. So Sasha, what are your thoughts on Ozempic, and should our patients take it or not take it? And is there any interaction with common drugs like Afinitor or somatostatin analogs, etc.?
So Ozempic, it's that class of drug is called GLP-1 agonist. There's a few. Wegovy is another one that was recently branded for weight loss. These were originally developed for treatment of diabetes, but since this notable side effect of slowing down the gut, making you feel more full, weight loss was found, they were then rebranded to help with weight loss. So there's a few different names, but they've gained a lot of popularity for the weight loss. So this is kind of controversial. My opinion, I would say for diabetes, I would be more in favor of continuing that treatment, but that would still be a discussion. For weight loss, it's controversial. My opinion, and I'd say most of my colleagues' opinion, is we don't know very much about it being used for weight loss yet. What we do know is it does have some side effects. So, it has been associated with gut paralysis. It essentially slows down how quickly your gut is digesting food. Some of the main warnings are it should be avoided in medullary thyroid cancer. And I think there's actually a newer warning in MEN to avoid it if you do have MEN, because it has been shown to increase your risk of developing those cancers. this is also controversial, but I also work with pancreatic cancer, and it is associated with a risk of pancreatitis, and we know pancreatitis can increase your risk for pancreatic cancer. We're not really sure about neuroendocrine tumors of the pancreas, but possibly a similar idea, an insult to the pancreas can increase your risk. So I would say, for weight loss, most of us still go back to the same recommendation. Diet and exercise are what work best. With these injections, there might be more risks than there is a benefit. So my opinion is to avoid them strictly for weight loss. For diabetes, it's more of a discussion. I would be more in favor. And the dosing is actually different, whether it's for diabetes or for weight loss.
Great thought. It has taken up like a storm. You hear about these drugs. And for the right patients, they are definitely very useful, right? So somebody with, significant weight issues, which is causing life-limiting or quality of life-limiting problems or cardiac or kidney issues and stuff, it makes sense. But I agree with Sasha. If the weight can be managed with diet and behavior modification and as exercise, that anyways, even if somebody's taking Ozempic, you have to follow that because the drug by itself is not going to be enough, right? And to keep it sustained that way, you have to kind of incorporate those things. However, Dr. Del River, what are your thoughts on MEN syndrome and Ozempic? And what are the current guidance, say, from the NETS community standpoint?
Okay, so one thing I want to say is as my endocrine background, I'm just going to use my endocrine hat right now, and the fact that, my job more is at medical oncologist, and I don't necessarily prescribe a lot of Ozempic, but that said, I'm still very up to date with what's going on with Ozempic, and by my colleagues, we usually discuss cases as well, and we do recommend Ozempic for weight loss. So that's kind of like one of the things, because weight loss is also associated for having insulin resistance, and also is associated with increasing, depending on what the other comorbidities are, increase in cardiovascular disease. And we know that by lowering the weight loss, it can improve a lot of the other, comorbidities like high blood pressure, the insulin resistant, the lipid panel. So if that's, even though they may not have an obvious, diabetes, like the A1C or the hemoglobin A1C, is just to clarify, is measure the glucose in a 3-month period, and it tells me how your glucose is running in a 3-month period. But if it's no more than 7.5 or 8, but it's still is considered during the obesity based on the body surface area, we still recommend it. So the question is, like, in patients that I have seen with neuroendocrine tumors and then with lanreotide, I think the question is, like, if there is any interaction with Ozempic and the other medications that I'm taking. And that's something that obviously we need to discuss with our pharmacists. We need to discuss with your physicians to make sure that there is no severe interaction. I do agree it has side effects that you need to be mindful, and one of them is constipation and severe in many occasions as well. Acid reflux is another one. Fatigue is another one. So there you have to be mindful of the side effects related to Ozempic too. And like Dr. Chauhan said, you always need to, discuss that with your primary care physicians to make sure that they monitor that very closely. And now in terms of MEN, so that, we still is debatable because the risk of medullary cancer was found in rats, but we have not been able to see it in humans. That's is a cautious, and yes, if you ask me if I have MEN2B that have a risk of medullary cancer, absolutely, I will not recommend it. Even though it's kind of like the risk has not been really established in humans, but just because it was developed, I would still definitely not recommend it in patients with MEN2A or B, or any patient that have medullary cancer without any association with familial syndromes, not necessarily with MEN1. The other question is like, well, incidentally, we always have like these thyroid nodules, and that's very common on a neck ultrasound. We have these thyroid nodules, and that's very common. And sometimes the question is there is any contraindication for that? It's usually if the thyroid nodule looks okay, benign within the characteristics of the ultrasound, I don't think that's a contraindication. But that's kind of like different compared to medullary cancer. If we have a familial syndrome, or a known risk for medullary thyroid cancer, yes, I would not recommend it. If you have other thyroid nodules that may look benign, that may not be a contraindication.
Wonderful. Thank you so much. Again, this drug has really caught up like a storm. It's really good to have these guidance for our patients. Wonderful. Do we have any audience question? Otherwise, I'm going to ask some questions to keep the conversation flowing. Sorry? Okay. Yes. Yes, please. I think part of it is appetite suppressant. You just don't feel hungry. It's a GLP-1 inhibitor. So it's one of the chemicals that, this science has been, studied for several years, and we understood when we eat what kind of reactions happen, what hormones are released, what hormones make me feel full, and what hormones make me feel hungry. So it's based on that understanding. I think part of it is it's just makes you lose your appetite. That's my understanding.
Yeah.
Sasha and Dr. Del Rero, what are your thoughts on that?
I was going to say some of both.
Yes, I mean, I think the mechanism is that there is a hormone, that is regulated in your endocrine system compared with the pituitary gland, and it's called leptin. So, in what this medication does is inhibit that hormone, and by doing that, it makes you feel fuller immediately. It's telling your brain like you're full. That's basically what the medication is doing. So it's more about, the feeling of kind of like, decreasing your appetite more than decreasing the gut. But that's a side effect of the medication, of decreasing the gut.
And this is just one of my observation, and in the US per se, our portion sizes are big. If you go to Europe or for that matter to India, I've now started noticing the portion size is much smaller, right? So a big part of our lifestyle here is really the portion size. And so if we can cut down the portion size, either we don't feel hungry, or if we have strong willpower and kind of be very judicious what we're eating, I think that's the biggest key here in losing unhealthy weight, okay? Dr.
Can I make a brief comment about it as a surgeon? So we have a number of patients that are too obese to get a transplant. So we perform a bariatric surgery on them prior to being listed for transplantation. And the most common cause of liver cirrhosis in the United States nowadays is fatty liver disease. It's not even hepatitis anymore, it's not even alcohol anymore, it's actually fatty liver disease. So that's an ongoing problem for us. One thing that I tell my patients is that whether Ozempic or any medications or even a bariatric surgery, obesity is not by eating, it's in the mind. It's a mental disease, actually. It's kind of how you face your life. Because then you stop Ozempic and you regain the weight. Or then you do the bariatric surgery and then you regain the weight. And up to 20% of the patients after bariatric surgery regain weight. So the key point, I'd say, this satiety and then this loss of appetite actually will help the patient to change the eating habits. That's what changes. So whatever mechanism it causes, the patient's motivation to change their, I would say, the way they deal with food is what makes a big difference. And then you can eventually stop the medication, because who's going to take Ozempic for a whole life, And that's not how we live, right? And for the longer you take it, the more chances you have to have the pancreatitis and the complications. So those, I would say, those are canes to help patients to really change their lifestyle and the eating habits.
I absolutely agree. You know what? How it also ties in beautifully with management of NETs. The number one site where the neuroendocrine tumor likes to metastasize is liver. Most of our metastatic disease patients have liver mets. And eventually, where we get in trouble from the tumors is when the liver starts failing, right? The cancer continues to grow. We like to preserve normal level as much as possible by slowing the tumor, by shrinking the tumor. And also the normal part of the liver, you need to take a good care of that. You just heard number one cause of hepatitis in the US now is fatty liver disease. 50 years back, this was not even something that we heard of, right? So this is a completely lifestyle-related issue, right? And we are all guilty. We all like our breads. I definitely do. You know, Indian food's filled with cereals and breads, right? So it's very important to take care of your liver, the normal liver, because that's really doing heavy lifting and kind of, you know, so that's really, really important part of it. All right, Misty, you know, a question to you. From your experience from the nursing side of things, what is the common burning issues that our patients face and you get phone calls regarding, and what would be your sort of advice to our patients regarding, you know, because you helped us develop this program from ground up, and you also were part of our NETS program at the University of Kentucky. So what is your advice to the patient in large? What are some of those issues that you kind of handle behind the scenes, doesn't even come to us in the clinical side? Curious to hear your thoughts.
The biggest thing I would say is, kind of touched on it earlier, make sure that you're asking the question. There is no silly question. There is no question that we've not going to be upset about or we're any feeling about, honestly. We want to know what is going on with you. So the most common calls I get are asking questions that we went over, but maybe we said it in a way that didn't make sense, or we used terminology that was new to you. Ask the question, because I want to make sure you have what you need. We all want you to have what you need. We want you to know what you're doing and how you're doing it, because like Sasha said, adherence is hard if you don't know what you're doing. This is new to you. It's something we might do 50 times a day. We might explain it 50 times a day. But if it's the first time you've heard it, if it's the third time you've heard it, that doesn't mean you understand it how you need to understand it for you. We all learn differently. We all have different backgrounds. We all have different exposures. So ask the question. And if you still don't get the answer, or if you still don't understand it, ask it again, or say, can you explain that a different way? Because I don't think I'm understanding what you're saying, because what I'm hearing is this, but what you're saying is this. And that way we can understand, maybe we're just presenting it wrong. That is the biggest thing in our line of work that we see is communication. Either it's us not communicating well for you, or us not understanding what you're communicating to us. So our biggest goal, and that's what we were trying to build our program around, is making sure that we're asking the right questions for you, because a lot of you have seen other providers, or as you go on, you will see other providers. We want to make sure you're getting the right information, and that you're also being able to get what you need as things change. If you've been taking the same drug for 5 years, that's great. If it's not working, you may not know it's not working, because to you this is now normal. But for us, we find something that could be better for you. So that's why we want to be better about our communication, but we need your help and your patience as we grow with that. But we also want you to be comfortable. Ask us. We don't know what your day-to-day is. There's someone I spoke to earlier that their day-to-day is not a comfortable thing, but it's now their normal, so they don't think to ask about some of these things at the office when they go see the doctor, because for them it's normal. That doesn't mean that it's how it should be. So please communicate. That's what we want.
I completely agree. I think it's actually very well documented. People have written research paper on it. When a newly diagnosed patient sees his or her oncologist for the first time, half of the information when they walk out is washed away. They don't remember the stage, they don't remember their grade, they don't, all the stuff that we go over, right? It's very normal. You're kind of dealing with a very stressful situation, and there's a lot of moving parts, right? So completely agree. You will not bother your team, your medical oncology clinic team by asking more questions. If you have to revisit a lot of things which you didn't fully grasp in your first meeting, hey doctor, because a lot of time when we do the staging, grading, and we kind of go over broad game plan, patient comes back and then they tell us, hey doc, can I still be cured? When we kind of went over, but it doesn't offend us, okay? We're happy to go over that again, because it's really important for us to understand what we are dealing with so that we can understand our goals and how to get to those goals, right?
We don't have a job if you don't ask, okay?
Yes, that's true.
That's what we're here for.
Yes, the AI is about to take that, by the way.
Can I make the simple, sharp surgical comment?
Yes, sure.
If your physician or if your team, if your provider is not able to provide you with the answers and to understand and acknowledge that, change the provider, change the team, you know.
Yes.
Well, you know, just like everything in life, there's a good and a bad and the average, right? So find the doctor and the team you trust and you have a good relationship with. I think that's the key here. Terri, how about we do the concluding question with you? You have tremendous amount of experience in treating, managing cancer patient and particular neuroendocrine cancer patient. What have your experience been, especially with regards to our community? You cater to a lot of Hispanic patient population as well. So through your pearls of wisdom, what are some of the challenging situations that you often incur, and what are your advice to patients that they can do to get better care? What would be your advice to our community?
We see at our center many individuals from Miami-Dade County, Broward, Palm Beach, down south in the Keys, and from really all over the world and the rest of the United States. One of the biggest things is the cultural aspect. Here in Miami-Dade, with our Latin community, very often many generations of the family will come to the first appointment. And sometimes if the individual with the diagnosis is elderly, they're okay with the diagnosis and might not even want treatment, but the family members push for it. It's our role to manage that in the room and really size up the room and distinguish what's going on and let the patient speak for themselves. We also see individuals who come alone. And although our role is to extend life as long as we can, sometimes by the time the patient gets to us, it's not possible to extend very long, whether it's this diagnosis or the other diagnosis that I spend a lot of time working on. As far as the community, something that I've done over the last chunk of years is I've educated other nurse practitioners and physician assistants from other specialties on how to potentially diagnose a NET, mostly carcinoid syndrome. Many of you, or maybe you know people who bounced around for years before they got their diagnosis. Anybody? You were told you had IBS, you were told it's gynecological cramping, all kinds of things. You went to your provider, but they didn't know to look for this. I've done talks where we've had NPs and PAs attend from the emergency room, from gynecology, PCP, GI offices, etc., and just given them the straight, this is what a NET is. Like the first slide, I think it was either you or Dr. Anthony had, talking about what it is and how we could potentially identify this in the community non-oncology setting. People call me all the time, GI NPs. You know, my patient's complaining of this, this, and this. What test did you tell me to order 3 years ago to see if I can rule them in and then refer them? Community outreach is really, really important, again, to people who aren't even in this space.
Wonderful. I completely agree with Terri on all those wonderful remarks. I think since we don't have a lot of questions and you guys have been really gracious in staying back all the way till the very end, hopefully we won't have a lot of traffic today being Saturday, you know how Miami is. I really want to thank all of you, my fellow panelists. I think we will conclude our last session here. I would like to invite Marian, if somebody can find Marian for this last words to say goodbye. I think we had a very good first inaugural Miami Nets meeting. What do you guys say, right? And Thank you so much for our sponsors. A big round of applause to them for sticking around till the very end. Thank you to our host, NCAN. They've been doing trailblazing work for past 20 plus years. When Marian has probably told you the story when she first started. She started with N of 1 and then 6, and then now she has helped literally not hundreds but thousands of neuroendocrine tumor patients across the country. I've personally, in last just 4 or 5 years, I've forgotten how many meetings throughout the country. So they're doing tremendous amount of work. Her, Bob, the co-founder of NCAN, and the team of NCAN. A big round of applause for them for this amazing work. And the biggest round of applause goes to all our patients. You guys are our motivation. This is the reason why we do what we do, right? The reason why we are here on a weekend doing this is because you guys give meaning to our work, to our life, and it makes us feel like what we are doing is our calling. And then we get up every single day, despite hundreds of messages on Epic. But we are super excited because we do see the suffering. We do want to help the patient, and we do one day want to find a cure for cancer. And in this room, we are the net enthusiasts. We want to find a cure for net cancer. Okay. So thank you so much for wonderful community and supporting us. Hopefully next year we make it even bigger. Our goal for next year is 200 plus patients and moving on and forward from there. Thank you so much. Marian, over to you.